I now have the privilege as well to introduce Dr. Marc Patterson. He's professor of neurology, pediatrics, and medical genetics at Mayo Clinic, where he also serves as chair of the Division of Child and Adolescent Neurology and director of the Child Neurology Training Center. He's very actively involved in national and international organizations such as WHO, the World Health Organization, the Institute of Medicine, and the American Board of Psychiatry and Neurology. In addition to treating people with NPC, Dr. Patterson conducts research on this and other neurometabolomic diseases. So, Dr. Patterson was selected by a consensus of the patient organizations to represent the community's top clinicians, several of whom are also with us today. So, Dr. Patterson, delighted to hear from you.
Tim, thank you very much for that kind introduction. I'd like to thank the Parseghian Foundation for their support of this meeting and their continuing role over many decades now in this disease. I'd like to thank all of you who are here. This is called a patient-focused drug development meeting, but this is actually a meeting of experts, because if you have Niemann-Pick disease type C or you have a child with Niemann-Pick disease type C, you are the experts in this disease. And anything I know, I have learned from you, and I thank you for that, and I thank you for the privilege of working with this community over the last 30 years or so now. Now, I have lots of disclosures here. All I would say about this is my attitude has been if someone comes to me and wants my opinion about a drug or a trial, I'm happy to share it. Sometimes they don't agree with my opinion, which is perfectly fine. And as you can see, I do quite a lot of other things as well to keep me out of mischief during the long Minnesota winters. I should also explain I'm not wearing a jacket because I can't cope with the blistering heat here in Washington after just coming from Rochester. My talk's going to be quite simple. First of all, to say, what is this disease, Niemann-Pick disease type C? Again, I know most of you in the audience are all too familiar with this, but this is just to give an overview. What are the unmet needs, again, which you live with every day? What's the current standard of care? And what are the opportunities for progress? Well, Niemann-Pick disease type C is an autosomal recessive disorder. It's an atypical lysosomal disease. The concept of a lysosomal disease came about a decade after the lysosome was first recognized in the mid-1950s by Duduve, and then Hares chose a disease called Pompe disease as the model for a disorder in which there's excess storage of substrate within the lysosome because of deficient action of a hydrolase, an enzyme which breaks down that large molecule or substrate. Now, that definition fits very well for most of the 50 or 60 diseases in this family, but it doesn't apply to Niemann-Pick disease type C because there are two genes which cause an identical disorder clinically, or with a great deal of overlap in any case. Neither of these genes is an enzyme, and that's very important in terms of understanding how the disease works and how one might approach treatment. This is a very rare disease. In fact, I've used the term ultra-rare. I had the opportunity to testify before the Senate last year, and I proposed the concept of ultra-rare diseases. Rare diseases are those that affect 200,000 or fewer people in the United States, according to the Orphan Drug Act. I would suggest ultra-rare as those being that have a frequency of 1% of that or less. If we had 2,000 patients with NPC, imagine all the trials we could do. It is an ultra-rare disease, and so that's very important in terms of the way we plan clinical trials and execute clinical trials. We don't have the luxury of large numbers of patients to choose from, and that, I think, has a very big implication. This is a disease that can present at any stage across the lifespan, beginning in utero, right through to what, now that I'm in my 7th decade, I call maturity. The oldest patient I've diagnosed was 65, and she didn't present until after her last pregnancy when she had tremor in her early 40s. So this is a disease that can affect people at any age and can strike very unexpectedly. We've already mentioned there are two genes, and they impair the trafficking of lipids and other large molecules within the cell. They're not enzymes. The result is that we see accumulation, particularly of free cholesterol and glycosphingolipids, which are complex lipid compounds within the cells. There are many results of this. There is an inflammatory response, which has been explored to a limited extent, but certainly in animal models, limiting this inflammatory response can have some benefit. There's also an acceleration of the normal process of programmed cell death or apoptosis, and interestingly, it's been known since the work of Richard Hawkes in Calgary for more than 25 years now, that this occurs in a very specific pattern of stripes in the cerebellum. And in fact, there's relative preservation of the Purkinje cells within the stripes that are positive for a compound called zebrin, which co-localizes with a heat shock protein. Okay, I think most people who've been to meetings have seen this diagram, and I can't improve on it. This was published by Marie Vanier in 2010, and it emphasizes a number of things. One is the presentation of this disease across the lifespan. It also emphasizes the fact that these presentations differ. So in fetal life and in the perinatal period, this is predominantly a visceral disease, one which affects the liver, the spleen, and the lungs. Now, the liver and spleen involvement is certainly detectable in terms of laboratory tests or pathological tests, but it doesn't seem to be terribly important in the course of this disease once we get past early infancy. We don't know for sure because we don't yet have curative therapy to sort that out. What we do know, though, is that once you get beyond infancy, this is predominantly a neurological disease, and it's a progressive neurological disease in which the symptoms reflect the progressive dysfunction and loss of specific populations of neurons throughout the central nervous system. And so in early infancy, children may be delayed and have low muscle tone, which is a very, very common presentation in child neurology. They may have no other specific findings until the first signs appear of the vertical supranuclear gaze palsy. That's not something we see in infants because physiologically they don't have well-developed saccadic eye movements. As time goes by, the progress of the disease is often quite insidious, so children may appear to be clumsy. You'll hear testimony from some parents and experts about how children are diagnosed with attention deficit disorder. Now, I want to stop and make a small point here about the word diagnosis as opposed to label. There are many labels we use in medicine. Attention deficit hyperactivity disorder is a label for a collection of symptoms. It doesn't tell you what's causing it, and it can be a symptom of many brain diseases, innate and acquired. Similarly, cerebral palsy is not a diagnosis. It's a label with many causes, and so on. Neonatal hepatitis is a pathological description of tissue obtained from the liver at biopsy. It doesn't tell you what's causing it. And that's very important. As physicians, we have to recognize the fact that we're sometimes applying a label rather than making a diagnosis. A diagnosis implies we understand the relationship between clinical symptoms, between the gross pathology under the microscope, what we see with an electron microscope, and what's happening at a molecular level. That's a true diagnosis. And I can tell you, as someone who sees patients from 8 to 5 every day of the week, we rarely make diagnoses. We apply lots of labels. Okay, that digression done. Again, if we come back to this group of children, those who present in infancy, as I say, may just have developmental delays and low muscle tone. They have what appears to be clumsiness, which is common. I'm very clumsy myself. But it gets worse over time and becomes clearly ataxic. But it's a very insidious development. It's often difficult to define the point at which that occurs. And in fact, defining the onset of neurologic symptoms can be very difficult in this insidiously progressive disorder. So finding points we can measure is one of the great challenges in this disease. As children get older, it becomes apparent that they have problems with their gait. Some children will present with speech delay or problems with their articulation, or typically both. And about this time, we'll often see the first presentation of a symptom which is very characteristic of this disorder, and that's gelastic cataplexy. And cataplexy is a sudden loss of muscle tone that's evoked by strong emotion. And in fact, it's a sudden intrusion of a fragment of rapid eye movement sleep at an inappropriate time. And we know that this is accompanied by loss of the cells in the hypothalamus that mediate this function, and in fact the product of those cells, called orexin or hypocretin, is deficient in Niemann-Pick disease type C. This is one of the symptoms which is often susceptible to symptomatic treatment with tricyclic or similar drugs. When the onset is a little older, children may present simply with difficulty in school. Someone who's doing well as they reach, say, the 3rd or 4th grade begins to have problems with some of the basics, with reading and writing, again with their attention. Ataxia is often overt by this time, and many children may begin to experience seizures. And as you'll hear, again, these can take many forms. Some fortunately, are relatively brief and easily controlled. Others can be extraordinarily difficult to control, and then we have the difficulty of sorting out how much of the child's manifestations are from adverse effects of anti-seizure drugs and how much of their manifestation is part of the underlying disease, and that's not easy to do. As time passes and we see the onset in teenagers and young adults, although the motor findings, in my experience, are always present, they're often overshadowed by cognitive and psychiatric problems. So again, sometimes we see people in high school or in college who've done well and begin to have difficulties with their work that they didn't experience in the past. Sometimes children can present with overt psychiatric presentations, such as treatment-resistant depression. They can mimic bipolar disorder. Some teenagers look as if they have schizophrenia. And so again, these are common disorders. Depression occurs in up to 20% of the population, so recognizing that this is a manifestation of this disease can often be a diagnostic challenge. And again, this is a synthesis. I recognize that everybody's journey is unique and that this probably doesn't describe anybody exactly, but I think it's a synthesis of the experience that I've learned from many patients over the years. This gives you an idea of something that we also recognize quite well. This is again from Marie Vanier's work, where she looked at 100 French patients in whom they had good data. And basically you see patients who have no neurologic signs are shown, or a period in which they have no neurologic signs are shown in the green bars. Patients who have neurologic signs and have passed away are shown in red, and those who are still living at the time of this study and had neurologic signs are shown in blue. And you can appreciate what makes sense, and that is the earlier the onset of neurologic disease, the more rapid the progression of this disorder. In fact, that's been shown in numerous studies that although there's no absolute number one can pick and we can't predict the course in any individual, there is good evidence that the earlier onset disease progresses more rapidly than later onset disease. This has actually been the case in every inborn error of metabolism that I know of, and it implies the fact that there is more severe dysfunction of the gene product, which causes the earlier presentation and the more rapid progression. Of course, this emphasizes the importance of early diagnosis and intervention, which is a huge problem for this disease. Most studies suggest the average delay in diagnosis is around 5 years. We think it's getting better with some better diagnostic tools, but it's still a huge problem. Of course, there are many ways to address that. Now, as you know, I'm a neurologist, and neurologists are like real estate agents. Everything is location, location, location. And so when we see a patient, we want to say, how can we relate this symptom to dysfunction of one or more places in the central nervous system? Because recognizing that pattern will help us recognize the nature of disease. Now, I have to say the problem with this is that by the time there's a clear-cut pattern of disease, there's been a lot of injury to the nervous system. And in an ideal world, we'd be making this diagnosis long before we could see these symptoms. But let me speak to this. The brain stem, the center of respiration, the control of the cranial nerves, also controls vertical gaze, and so we can exquisitely localize the vertical supranuclear gaze palsy, which is so characteristic of this disease, to the rostral interstitial nucleus of the medial longitudinal fasciculus. I challenge anybody to say that this early in the morning and not stumble over it. But that's very characteristic of this disease. We don't know why, but this is a sign which, at least in my experience, is universally present in children and adults who have neurologic disease. The literature doesn't suggest that, but I will tell you from having seen patients over many years, it's always missed, or almost always missed, because people do not examine rapid voluntary eye movements or saccades, but it's very important. The cerebellum, in many ways, bears the major brunt of this disease, which is the case with many other lysosomal diseases. There are cells called the Purkinje cells, which transmit all the output of the cerebellum. Now, despite the fact that the cerebellum, the little brain, sits in a relatively small volume within the skull, it contains about 80% of the neurons in the brain. So it's hardly surprising that this incredibly complex processing center, when dysfunctioning, causes so many symptoms, and particularly this clearly explains the ataxia, the dysarthria, the difficulty with articulation, and the dysphagia, the difficulty swallowing. It probably plays a role in cognition and in language as well, and there are a number of studies in neuroscience that are supporting a much broader role for the cerebellum than has traditionally been recognized. The diencephalon, or midbrain, is the site of central regulation of many very basic bodily functions, including the sleep cycle. And so This is the site of location of gelastic cataplexy, which we mentioned. It's also the site of another symptom which I think has not been so well recognized and described in the literature, which is a huge challenge, I think, for families, and that's sleep inversion, where the affected individual is awake all night and sleeping during the day. So this, in addition to the other disruptions the family has to cope with, this is really an enormous burden and one that can be very challenging to manage. The basal ganglia are involved and produce dystonia. This often is, again, insidious in its presentation with what's called action dystonia, where one foot or hand may turn in whilst walking or participating in other activities, and it can become generalized and quite disabling. And of course, in general terms, we can localize cognitive deficits, psychiatric symptoms, and seizures to the cerebral cortex, or at least the circuitry that involves the cerebral cortex, but bearing in mind that, in fact, the basal ganglia and the cerebellum also participate in these functions, so the localization is not quite so clear-cut as we think. But these are important points because we know that multiple levels of the central nervous system are involved in this disease, and treatments have to be able to reach all of these neurons to be effective in alleviating symptoms and improving the outcome. Well, what are the unmet needs? Well, I think we've already alluded to some of these. We have an incomplete understanding of disease mechanisms and clinical heterogeneity. Many very talented scientists have investigated this, but we don't really understand exactly what these gene products are doing and how that translates to symptoms, although our understanding is improving. We still need long-term natural history data, and of course Denny Porter and his colleagues have done wonderful work at NIH. There have been other prospective databases, including the large one in Europe, and now of course there's the International Niemann-Pick Disease Registry, which is a patient-organized and owned registry, which I think is a wonderful approach to solving this problem. We still need to know more. This disease was first described in recognizable form in 1958, but after 61 years, we still have much to learn. And of course, if we understand the clinical symptoms and their progression better, we'll be able to link that ultimately to so-called surrogate markers. We have many biomarkers, that is, things we can measure which correlate to the presence of disease, but what we need are things we can measure which correlate to the progression and the outcome of disease, and that's something which is not yet available. We also need to have generally accepted patient and caregiver initiated and endorsed clinical outcome measures, which is what this meeting is all about, because what may be easy for us to measure or something that's been done in many studies before might be interesting and reproducible, but if it means nothing to the patients or the families, it's really not helpful. And there are examples of other diseases where certain things have been measured which give positive outcomes, but where the outcome for the patient is not so good. I've mentioned the importance of surrogate markers of disease progression. One thing that is lacking is studies of symptomatic therapy. Treating patients' seizures, treating their dystonia is really important, but we don't have good data. We've got lots of anecdotal data, and that's an area I think we have opportunities to work together and make improvements so we can really answer those questions in a more definitive way. And of course, we need approved disease-modifying therapy. There are many promising agents under investigation at the moment, but nothing that's yet approved. Clinical outcome measures, I'm not going to go into the details, but at NIH actually we published a scale many years ago which didn't quite catch on, but basically everything since then has been based on the work of Merthe Pineda and her colleagues in Barcelona, who published this study in 2006, the so-called Pineda scale. Denny Porter and his colleagues expanded this in a fashion which was suitable for investigation in an environment like the National Institutes of Health, where it's possible to do a very intense workup over a period of days or a week. But now there's been some more recent work asking the question, well, do we need all of these measures? Could we simplify this and get the same information? And this publication by Fran Platt and her colleagues just last year suggests that that may actually be the case. I'm not going to talk in detail because talking about any one intervention could take up this entire meeting and has taken many entire meetings. Just to point out the encouraging news, if you go to clinical trials, there are 7 trials recruiting in this disease, 2 that are active but not currently recruiting, 2 that are not yet recruiting but are planning to do so soon, 8 have been completed, 2 were terminated, and 1 is, quote, available. Now, again, all of these are promising. They're all looking at interventions that I would argue are downstream to the major problem. And so we would hope that if one or more of these are successful, they will stabilize the disease, and I think most of us would regard that as a huge leap forward. As I said, there's a lot of promising data around, but nothing that's so far led to an approval. But that is obviously something we all are very anxious to see. And there are just some references there, and I won't, we could publish many others as well. So what is the current standard of care? Well, you know, this is very difficult, and one of the things that I've had the privilege to do with a number of colleagues over the years is to publish some guidelines. Now, we have to recognize that the best available data is not what we'd want. In an ideal world, we would have randomized, controlled clinical trials of everything we do in this disease. Well, of course, we have very little of that. So the next best you can do is put people together in a room and establish consensus. That is the final product of a lot of very opinionated people shouting at one another, but that's okay. You come up with something you can all live with, and that's, I think, a useful product. And I've been very enthusiastic about doing this because if we have peer-reviewed, published data, that becomes a tool for the community, and that's very important because I know that one of the struggles that families have is in receiving reimbursement for the care their children need. And you have enough to deal with without fighting with third-party payers. And I know that everybody has had that experience, and I've tried to help with many, many letters and calls over the years. So having something published is very important for the community. It draws a line in the sand. It said, here's a starting point. We can move on from here as we get more data, and also establishes the weakness. So I think that's a useful thing. Current standard of care, of course, involves supportive care. It's very important to recognize, as you will hear, and everybody here knows, that this is not a disease that affects individuals. It affects entire families, and by extension, the community. The burden of disease on individuals is huge, but it's huge on families, and it costs the community. I know there are many people who have to cut back on their work or give up their job to provide care for their children. This is a huge economic cost, not just for the family, but for the whole community. So these are rare diseases that have repercussions that extend far beyond the affected individuals. Okay, so I am done, and I think I am on time. So I thank you for the opportunity to speak. And again, I think this is a wonderful opportunity for this community to work together. This is a terrible, devastating disease, as you know, and we'll hear today. But I think it's encouraging that everyone has passion. Sometimes this leads to differences of opinion, but we all want the same thing, which is better lives for people and families affected by Niemann-Pick C. And I think this meeting is a wonderful way to accomplish that. So thank you for the opportunity to participate.